This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Gregg from Mayo Clinic in Jacksonville, Florida. I have the pleasure of interviewing Jonathan Rohrer from UCL Institute of Neurology in London, England. John is the senior author on a paper published in Neurology Genetics titled Executive Function Deficits in Genetic Frontotemporal Dementia. Thanks for joining me today.
No problem, Greg.
Your team's work here explores the potential contributions of executive dysfunction to disability, and in this case, associated with frontotemporal dementia. Now, as a clinician, you'll appreciate what I appreciate. Our clinical landscape is dominated by patients who typically complain of memory problems and daily challenges that associate with memory loss. But where your paper really comes in and adds something to the mix is it's an important reminder that there are actually many other contributions and contributors to cognitive impairment, including executive dysfunction. On that topic, it's fair to say that executive dysfunction can be a challenging problem to recognize and perhaps even more costly when we miss it in the clinic, given its obvious association between impairment in judgment and decision-making with issues in the workplace that can lead to job loss, challenges with financial management at home that can lead to financial peril, and of course, susceptibility to scams. Plus, when we combine executive dysfunction with disinhibition and impulsivity, things that commonly come from the same networks, it often means that decisions are made all the more quickly by some of our patients. Now, before we get too far into the motivation for this work and the findings, can you set the stage for us? Tell our listeners a little bit about the patient population here that's really at the heart of this manuscript.
The participants in this study come from an international consortium that I've been running for the last 13 years now. So it's a study called GENFI, or the Genetic FTD Initiative. It's a multi-center European and Canadian study. At the time of this paper, we had 30 centers involved. We're now up to almost 50 centers, but it's a study that's really got the goal of trying to understand this condition, frontotemporal dementia, better, and particularly focused on the genetic forms. And of course, the end goal being to find a cure for these illnesses, but really the starting place of getting a common ground from all these different centers around the world to study the condition better.
Excellent. So certainly a very unique population of participants here. As you point out in the manuscript, and as we know, executive dysfunction is common in frontotemporal lobar degeneration, and it's reasonably well studied in patients who have sporadic forms of frontotemporal dementia, but less or maybe even not at all until now in patients with familial FTD. What's particularly unique about this participant population? What opportunity are you seizing on here as we explore the contributions of executive function in this familial cohort?
One of the big reasons we set this study up in the first place was because many centers had been studying family members from families with genetic frontotemporal dementia for many years, because these people from families, these are autosomal dominant illnesses. So the siblings and the children, the first degree relatives, they know that they are at 50% risk of developing frontotemporal dementia. Many of them have gone through genetic testing and absolutely know that they're going to get this condition. But many of those people are 5, 10, 20, 30 years or even more away from developing symptoms. So studying people at risk of developing genetic frontotemporal dementia allows us to understand cognitive deficits, not just in our normal day-to-day practice, which is in the clinic seeing people who've already developed symptoms, but in a window that can be many years before those symptom onset. So to allow us to study the onset of any cognitive problem and to understand what that is, how that changes, and therefore, of course, whether we can intervene earlier when these symptoms first start. And that's always been the goal of GENFI, is really to get to a point where we understand the disease well enough that we know the time point which we should really be intervening before people develop executive function deficits or cognitive deficits.
It is indeed a great opportunity in this cohort of highest risk participants who, as you point out, don't yet have symptoms, but are certain to develop them if they live long enough. So how did you capitalize on that in this study with respect to executive function and dysfunction?
This study, we focused on one of the data freezes. That's when we freeze the data and start to look at a group of individuals. We had 752 individuals, and they are from the three main genetic causes of genetic FTD. So mutations in the genes tau, or microtubule-associated protein tau, progranulin, or GRN, and C9orf72, the most common genetic form of FTD. So split between those three groups. And each of those groups is staged into those people who are asymptomatic, prodromal, so not yet meeting criteria for FTD, but with some subtle symptoms. And then those that we have a small number of people in the study who are fully symptomatic and will people who will have been diagnosed in a neurology clinic. So it allows us to look really are there differences across these three genetic causes of FTD? And at what point from asymptomatic to prodromal to fully symptomatic do we start to see executive function deficits? And we made use of the GEMFI psychology tests, the GEMFI psychology battery, which has a number of different executive function tests.
Tell us what you learned. What are the findings in this unique cohort?
Certainly, by the time people have symptoms in any of the three genetic forms, there are executive function deficits. And that would be expected. In the international Raskowski criteria for behavioral variant FTD, executive function is one of the 6 core deficits that are in the diagnostic criteria. But here we are also seeing, and it's particularly in the C9orf72 group, that there are significant group differences in quite a number of the executive function tests, not just at the prodromal stage, but at the supposedly asymptomatic stage of the disease. So even using these pen and paper traditional psychological tests of executive function, we can pick up this very early change, and particularly in the C9orf72 group.
Working backwards, clearly executive dysfunction exists in the symptomatic stage. It's part of the core criteria, but sounds like you're uncovering a potentially subclinical manifestations that up until now we may not have known to look for, and we may certainly be missing in some of these high-risk patients. Intriguing, as you pointed out, so the division between the genes and possible pathologies associated with these genes, but where our C9 carriers seem to be most at risk, and even before their symptomatic stages. Why do you think that is? And in particular, is there something protective for patients with progranulin or MAPT mutations?
We don't know the answer to that, is the bottom line. Some of it is anatomical, so some of it is which areas of the brain we see being the earliest involved in the different genetic groups. Some of it is potentially about the underlying pathophysiological process. For instance, there is other work suggesting that in progranulin, there isn't neurodegeneration and changes seen until quite late in the pre-symptomatic period, really just before symptom onset, and often changes both on brain imaging and in cognition happen relatively late in the pre-symptomatic period. Whereas in C9orf72, which is an incredibly intriguing disease, there are previous work which suggests that there are imaging changes that may be happening 20 or even 30 years before onset. There is work suggesting that maybe there is some kind of neurodevelopmental rather than just neurodegenerative change in C9orf72. So it's likely that there are different biological changes, and some of that is where the disease is, but some of that is what the actual pathophysiological changes are that are happening.
We're referring to these patients as prodromal, some of those with subtle changes or maybe completely asymptomatic. But does this level of executive dysfunction that you're seeing in some of these neuropsychological measures, does it rise to the level where with maybe more in-depth questioning, more functional-based measures, we might actually see impairment in daily life, perhaps say in a challenging workplace environment or other home finances, filing taxes, those sorts of situations that we all encounter throughout the average year?
That's a really difficult question. Lots of studies like this look at group differences. And whilst group differences can be statistically significant, then it has to go back and think, what does that mean? So does that mean, when you have a group, does that mean that all the people in the group are a little bit different, or does it mean that there is a subgroup with a bigger difference? And I think one of the core bits of work that we don't address here and that absolutely needs to be addressed is, what does this mean on an individual basis? Are there a group of people who actually have no cognitive deficits for a long period of time and then develop some cognitive deficits around symptom onset? And are there another group who have cognitive deficits from young? Now, when we look at occupation, there are, of course, many people with C9orf72 expansions who know that they carry that, who have very high functioning professional jobs which require a high level of cognition and education. And of course, there are many people who have got to a high level of education. So that's a really difficult question. And it's something that we are trying to address really in combination with our community of C9orf72 family members, because when we feed back this kind of work to the families, they want to know the same questions you're asking. They want to know, what does this mean? And they are small changes, and it may be that these just don't rise to being clinically significant in day-to-day life until nearer to symptom onset. But there's lots of work to really understand what this means for people.
And worthwhile work to do from a translational perspective. What do you see then as the practical implications of these findings? Perhaps for the practicing neurologist who's seeing that family member who maybe has a known C9 mutation in follow-up in the coming months. Is there roles for additional screening for symptoms and maybe bringing in a collateral source, someone that knows the person well, to ask them about function? Is there any specific counseling that we should be thinking about with individuals from these families?
Yeah, there is a worldwide thought process around this, not just from our study, the GEMFI study, but the equivalent study in the US, which is the all-FTD study, and a number of the ALS studies around the world, trying to work with family members to understand what it is they want in terms of care, really in the days before developing symptoms, but in the many years before developing symptoms. Traditionally in neurology, so in my clinic in Queen's Square at UCL, we have traditionally, of course, seen people when they develop symptoms. And we commonly followed people up in research who were at risk. And at the time they became worried about symptoms, we saw them in our clinic. But times have changed, and people know that they are at risk of these genetic degenerative disorders. And people want us to try to define a standard of care in the neurology clinic. And they want us to do that with them. Some of that is likely to be cognitive testing, but we need something that's going to really help people to define where they are. What people want to know, the big question that all family members want to know is, when am I going to get symptoms? Is that going to be in 5 years? Is it in 10 years? Is it next year? And one thing that this paper tells us is that cognition actually maybe not that maybe baseline cognitive testing isn't that helpful, because the changes can occur at such a distance before onset. We know that from other studies, things like plasma neurofilament light chain, we know that changes much more closely to symptom onset. So I think one of the things we're defining at the moment is, how do we really better inform family members about where they are in that process? How often should we be seeing people? How often should we be doing executive function testing? How often should we be doing other things? And those things are things we should be doing with families, and things that we're really trying to define and get a worldwide standard for now.
Well, certainly new insights of this nature make for great papers. Congratulations. They also make for great podcasts, so thank you again for joining us. But as we're talking about, raises a lot of unanswered questions. And so I think you've given us some insight here, but what do you see as the next highest priority steps in the GenFi cohort when it comes to understanding the pathways here that lead to executive dysfunction, the screening that we might need in clinical practice, and really what's going to make a meaningful difference for our affected families?
So there are a couple of things. One is that we want to have a really good standardized measure that we can use as an outcome measure in prevention trials. So prevention trials are the next generation for us in terms of not just doing trials in people with symptomatic genetic FTD, but really trying to get to a stage where we can allow family members to go into potentially gene therapy trials in C9, that potentially gene silencing therapy trials, where we can have a outcome measure that, because they're pre-symptomatic, is not going to be necessarily a clinical measure, but might be a executive function measure or a cognitive composite measure. It might be a measure on a digital biomarker. And then we want to try and think about when those prevention trials should be. It's clear that if people are heading into their 40s and 50s and they're likely to be nearer to symptom onset, that maybe we would include those people in a prevention trial. But should we be including people in their 30s, in their 20s? One of the things that is new to GEMFI is a study called a NeuroDev study or neurodevelopment study run by Liz Finger, who's a neurologist in London, Ontario in Canada, which is really starting to look at people who carry a C9orf72 expansion but are actually teenagers, and whether we can detect either brain imaging changes or even executive function changes even earlier than we would traditionally do in an adult study. So it's moving to prevention trials, moving to understanding individuals, not just groups, and understanding what the very earliest changes are and whether those are even earlier than we would do in traditional studies.
Precision medicine approach. Love to hear about it, and certainly we look forward to discussing further findings from the GENFI cohort with you and your team.
Great. Thank you very much.
Thank you, John, for taking time to discuss this important paper and sharing your unique insights. I've been speaking with John Rohrer, senior author on the paper titled Executive Function Deficits in Genetic Frontotemporal Dementia, which you can and should read in Neurology Genetics. Thanks for listening.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.